So it's not always easy in our situation. And here I want to point out the severely dilated left atrial appendage, dilated left ventricle, severely dilated left atrium. In our situation, when a patient is deteriorating or deteriorated and needs an intensive care treatment, an intermediate care unit, or if there is a problematic situation in the emergency department, we use echocardiography. Echocardiography in the intermediate care unit in the ICU is our standard, also almost a standard echo. In the emergency department, it's more towards a point of care situation. Of course, in the intermediate care unit and the intensive care unit, it's still more focused, but we evaluate the left ventricle, the right ventricle, of course, diastolic dysfunction. We always take a look at the LVOT, the stroke volume. We look at the VTI and the pulse wave Doppler at the LVOT, the IVC, the SVC. So we already, when a patient is administered to our intermediate care unit or intensive care unit, we have the echo as our first hand standard. Then we use lung ultrasound. In this case, you see a pleural effusion and you see this small area which is a consolidation of the lung, but in this case it's small, but still it looks compressed. So it's in this case a telectasis, so no pneumonia and most likely no tumor, as the effusion is compressing this small structure. So the lung is also part of the exam. We look for effusions, consolidations, B-lines or cometal artifacts. So we look for fluid, free fluid, and we look for signs of infection. Then we use the liver veins, the portal vein, and the kidneys, because if a patient has acute kidney injury, we always take a look at the kidneys anyway. So all the structures are not that far away, and we use the VEXAS exam also in our daily clinical routine. That is our easy approach, but of course, a very important point, and I mention it repeatedly, if it is still possible, then do the impossible and talk to your congested patient. In this case, a patient came to the emergency department. I was in the emergency department and the patient said, I'm dyspneic, I have edema, I'm sure I'm congested. It was a heart failure patient, and I did scan the IVC, it was dilated, and I did scan parts of the VEXAS, and in this case, you see the signal of the liver veins and shows digestion. So the clinical status of the patient, the clinical findings, the history is very important. So if it is possible, if the patient is not intubated, talk to your patient and figure out with the clinical findings and your ultrasound if the patient in this case is congested or needs volume. So to summarize, our standard is the echo. We look for all findings needed to answer our clinical questions. The lung is part of the exam. We at least look for effusions and B-lines or cometals. So we also look, of course, where we see effusions for consolidations by telectasis. The liver veins, the portal vein, and the kidneys, they are not that far away. And if you're used to the VEXAS exam, especially endlessly, so if you scan your patient from time to time, you get a better idea if the problem is congestion or if the patient really is hypovolemic. But again, it's not always easy, it's not always a straightforward answer. For the VEXAS, Doppler measurements are known for years, especially in heart failure patients. Also the hepatic veins, as I mentioned before, in constrictive pericarditis, but also the portal venous system. It was published initially with heart failure patients. The evidence for VEXAS is still limited but growing, and we combine the clinical findings and the VEXAS and the other scans with ultrasound to figure out what actually the problem is. And keep in mind, not every patient has to have a VEXAS grade 0. So sometimes a patient, in a heart failure patient, for example, can be a little bit congested, but not having severe problems because of the mild congestion. Breathing maneuvers can help. I don't like to do it in the VEXAS exam because it changes also the intra-abdominal, and breathing maneuvers can help. So if you hold the breath for the VEXAS exam, but very often it's not that easy with our patients. I tend to not use breathing maneuvers because most likely you will still get a good exam and then you do not have a change in pressures with respiration. That concludes the volume status and evaluation with ultrasound of the volume status.